Most people think that when a top surgeon recommends an operation, you simply say yes. White coat, diploma on the wall, scalpel ready, just sign on the line. I used to assume the same until I started noticing the patterns no one talks about. A man who walked into the OR for a minor back procedure and came out using a wheelchair forever. A woman who made it through heart surgery but lost nearly a year of her life to infections nobody warned her about. Here is the uncomfortable truth. The older your body gets, the more the operation itself becomes the enemy. Not the disease, not the injury, the surgery. My name is Dr. Adewale Method. I've been a cardiothoracic surgeon for over 20 years. And in this video, I will walk you through 5 operations that carry devastating, often hidden risks for anyone over 60. Think of it this way. You take a brand new pickup truck and an old sedan with 200,000 miles. You put both through the exact same off-road course. Do you expect the same outcome? Of course not. And yet for decades, mainstream medicine treated a 75-year-old patient exactly like a 40-year-old. Same surgical techniques, same recovery timelines, same drug dosages. That is finally starting to change, but far too slowly. Here is what actually happens inside an aging body under general anesthesia. The heart strains harder, the lungs struggle to clear the anesthesia gases, the kidneys process painkillers at half the speed, and the brain, this one shocks most families, the brain enters a fog that can last weeks, even months. Doctors call it postoperative cognitive dysfunction. In patients over 70, it happens far more often than any hospital brochure admits. Let me be crystal clear, age alone should never be the only reason to skip an operation. I have operated on 80-year-olds who recovered faster than some 50-year-olds. Age is just a number. But frailty is a medical fact. Roughly 40% of people over 75 show measurable frailty. That number jumps to nearly 60% past 85. The real question is not survival. The real question is recovery. So the real question is not whether you can survive the surgery. The real question is whether you can survive what comes after. Those are 2 completely different things. Surgery number 1, open heart procedures in frail patients. Coronary artery bypass grafting, or CABG, is one of the most common major operations in older adults. The logic is simple. Arteries blocked, we build new routes, and for the right patient, it works beautifully. But here's what the glossy pamphlets hide. Open heart surgery requires stopping your heart entirely. A bypass machine does the work of your heart and lungs while we operate. For a fit 60-year-old, that is tough but manageable. For a 78-year-old with diabetes, mild kidney disease, and early cognitive decline, that machine becomes a brutal assault on every organ at once. Studies show that in frail elderly patients, this surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, weeks of confusion, prolonged ventilator dependence. And here is the number that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this operation. So what is the alternative? In many cases, a procedure called TAVR, transcatheter aortic valve replacement, no chest opening, no stopping the heart, a catheter through the leg, far gentler on a body that needs gentleness, not a war. Does this mean refuse all heart surgery? Absolutely not. It means ask your surgeon one specific question: am I a candidate for a less invasive approach? That single sentence could change everything. Surgery number 2, aggressive spinal fusion for back pain. Back pain after 60 is nearly universal. I cannot remember the last patient over 65 who did not mention their spine. And the solution being pushed more and more is major back surgery, multi-level fusions, rods, screws, cages. Some spinal operations are absolutely necessary. If the spinal cord is being compressed to the point of losing bladder control or leg function, that is an emergency. But elective spinal fusion for chronic non-emergency back pain in elderly patients, the evidence is genuinely disturbing. A major study in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. And the complications were not minor: blood clots in the lungs, deep infections, hardware breakage, and something called adjacent segment disease, where the vertebrae above and below the fusion start crumbling because the spine's natural mechanics are permanently altered. Here is what frustrates me most. For many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. Same result, massively higher risk. A colleague of mine, an excellent spine surgeon, once told me, the best operation is sometimes the one you never do, I think about that line constantly. Have you ever been told surgery was your only option for back pain? Let me know in the comments. Surgery number 3. Major cancer resections in the elderly. This one is the hardest to discuss because the word cancer triggers an immediate primal response. Cut it out. Now, get it gone. I understand completely. I would feel the same terror, but 2 decades in the OR have taught me this. The goal of cancer treatment is not just to remove the tumor. The goal is more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient achieves the opposite. Take pancreatic cancer surgery, the Whipple procedure. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The operation takes 6 to 10 hours. In a younger healthy patient, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, yet the patient still dies within weeks from surgical complications, not from the cancer itself. That is called futile surgery, and it is far more common than anyone admits. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced failure to rescue. A complication occurred that the weakened body simply could not survive. The goal is not to remove the tumor. The goal is more good years. So what conversation should you have? Ask your oncologist this exact question. If we do not operate, what does watchful waiting, radiation, or newer targeted therapies look like for someone my age and health status? That question opens a door most patients never even knew existed. And sometimes behind that door is genuinely a better answer. Surgery number 4, elective joint replacement in sicker patients. Hip and knee replacements are among the most successful surgeries ever invented. I say that without hesitation. For the right patient, a new hip genuinely transforms life. People go from barely walking to chasing grandchildren in the park. Remarkable. But here is the catch for older adults. Elective means you have time to think, time to prepare, and crucially, time to ask whether your body is truly ready. Because the statistics are clear, in patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement, carry significantly elevated risks. Blood clots are the biggest danger. Clots form in the legs, travel to the lungs, become fatal pulmonary embolisms. In elderly patients with sluggish circulation, that risk is much higher than in younger patients. Add postoperative pneumonia from lying still too long, add hospital-acquired infections, the picture becomes far more complicated. I do not want to frighten anyone away from a surgery that could genuinely help them. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can slash complication rates dramatically. Some hospitals now require a formal prehabilitation program before they will schedule these operations for high-risk elderly patients. That is exactly the right approach. Has your doctor ever mentioned prehabilitation to you before a planned surgery? Most people have never even heard that word, and they absolutely should. Surgery number 5, emergency abdominal surgery. Now I need to pause here because this one is different. You do not choose emergency surgery, it chooses you. A perforated bowel, a ruptured appendix, internal bleeding from a fall or a medication. These situations do not wait for a calm conversation in an office, but here is why this belongs on the list. Knowing the risks in advance, before the emergency happens, changes how families make decisions in those terrifying 3 a.m. moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We are talking 30 to 50% in the most severe cases, not because the surgeons are unskilled, because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, lungs all hit simultaneously, and the inflammatory response that a younger body controls within days can spiral in an older body into something called systemic inflammatory response syndrome. When multiple organs start shutting down in sequence, it is as serious as it sounds. So what can you actually do with this information? 2 things. First, do not ignore abdominal symptoms. Persistent pain, unusual bloating, sudden changes in bowel habits after 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies. That one habit can save your life. Second, have the conversation with your family now, not in a hospital corridor at midnight. What are your wishes if emergency surgery is the only option? What quality of life matters to you? These conversations are not morbid. They are one of the most loving gifts you can give the people who will be standing in that corridor. We have covered 5 high-risk surgeries. Now let us talk about what you actually do with this knowledge. Because information without action is just anxiety. And that is the last thing I want to give you. Before any major surgery, planned or recommended, every patient over 60 should ask 4 specific questions. Write these down. Question 1. What happens if I do not have this surgery right now? A good surgeon will give you an honest answer. If the answer is nothing urgent changes in the next 6 to 12 months, you have time. Time to think, time to get a second opinion, time to optimize your health. Question 2. Is there a less invasive alternative? Medicine has transformed in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions, options that did not exist a decade ago are now available in most major hospitals. Question 3. What does recovery realistically look like for someone my age and my specific health profile? Not the average patient, you, your heart, your kidneys, your medications, your living situation. The answer should be specific, not generic. Question 4, and this is the one almost no one ever asks. What is your personal complication rate for this procedure in patients over 70? Surgeons track their numbers. A confident, honest surgeon will tell you. If they seem uncomfortable with the question, that discomfort itself is valuable information. Before I close, I want to leave you with something genuinely hopeful. This is not a video about fear, it is about options. And those options have never been more powerful. Minimally invasive surgery has transformed what is possible for elderly patients. Laparoscopic procedures, small incisions, camera-guided, dramatically reduce recovery time. Robotic-assisted surgery allows precision that human hands alone cannot achieve. And catheter-based cardiac interventions have opened doors for patients who would never have survived traditional surgery. Beyond the OR itself, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a knife. The body wants to heal. Sometimes our job as surgeons is simply to get out of its way and give it the tools it needs. Let me tell you about a patient. I will call him George, 72 years old, retired engineer, sharp as a tack. He came to me after 3 different surgeons had recommended open heart surgery for a blocked artery. 3 surgeons, 3 recommendations, same answer every time. George was not afraid of the operation itself. He was afraid of losing himself. He had watched his wife go through a major surgery 2 years earlier and come out confused, exhausted, and never quite the same. He told me, "Doctor, she walked in as my partner and walked out as someone I had to care for like a child." That sentence has never left me. When I reviewed George's full profile, his kidney function, his frailty score, his cognitive baseline, I sat with him for nearly an hour, and I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehab. The data for his specific profile showed comparable 5-year outcomes. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photo. He is standing at the top of a mountain trail in Colorado with his 2 granddaughters, both taller than him now, grinning like he won the lottery. The surgeon holds the scalpel, but you hold the choice. Here is what I need you to understand. The single most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, to request every alternative, to take every day you need. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine, more powerful than any operation I have ever performed. Let us bring it all together. 5 surgeries with serious hidden risks for people over 60, open heart in frail patients where less invasive alternatives now exist, aggressive spinal fusion where the evidence for pain relief is far weaker than most patients are told, major cancer resections where the goal must always be more good years of life, elective joint replacement in sicker patients where timing and preparation matter as much as the surgery itself, and emergency abdominal surgery, where the best protection is catching problems early and having honest family conversations. None of this means avoid all surgery. Surgery saves lives every single day. I have seen it, I have been part of it, I am proud of it. The message is simply this: be an informed patient, ask the hard questions, request the alternatives, get a second opinion, and if necessary, a third. Your age is not a weakness, it is a reason to be smarter, not quieter. If this video helped you or someone you love think more clearly about the surgical decision, share it. That one share might be the most important thing you do today. Take care of yourselves. Stay curious, keep advocating for your own health. You deserve a surgeon who explains everything and a medical team that treats you as a partner. And one last thing, everything I've shared today is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest conversation with your own doctor or specialist. They know your history, they know your body. And that conversation, informed, direct, and unhurried, is exactly where good medicine begins.